What's up, everyone? Floating Vent Guys back. So I figured today we go over triggering, as this came up recently on the socials, but also in rounds with the residents. So I figured I'd go over it and going to base it off of this carousel that I made a while ago that sort of went over triggering. So the question becomes, how does the ventilator know to switch into inspiration from expiration? So here would be the trigger I'm highlighting in blue for people that can see on YouTube and Spotify, here and here, meaning from expiration to inspiration. How does the vent know to start inspiration? We call that the trigger. And there's essentially a few different ways the vent can know how to trigger. So the first way the vent can know how to trigger is through the time. There's 60 seconds in a minute, depending on what you make the I time, meaning the inspiratory time. Let's say you made it 1 second, then the expiratory time would be 2 seconds, because that would be fixed. So the I to E would be 1 to 2. So you would have a breath start every 3 seconds. And you would start every 3 seconds, a breath would be triggered. If the patient wasn't breathing, they'd all be controlled breaths. Every 3 seconds, breath 1, 2, 3, breath 1, 2, 3, breath 1, 2, 3. So that would be with consistency every 3 seconds. And that's only if the patient is not participating, and these are all controlled breaths. These are based on the respiratory rate that you set. So if you set the rate higher or lower, then the vent would sort of switch on every X amount of seconds based on the math. So the one way that the vent can know how to trigger is through the time based on the respiratory rate that you set. Another way the ventilator can know how to trigger is through this spontaneous trigger. So imagine the patient wakes up and then he or she wants a breath. So how can the patient let the vent know that they want a breath? They can do this by influencing the circuit, and depending on what you set it to, the vent will pay attention to one or the other variable. So the first variable is the pressure. So the pressure, which we generally think is more of the more difficult way to trigger the ventilator. So what the patient has to do is sort of suck down on the circuit so much so that they start to influence the pressure. So if the PEEP here was 5 in the yellow, for those of you who can see I'm overdrawing blue. So if the PEEP here is 5, then what the patient has to do is sort of draw this downward to some number. You can set it at a pressure trigger of -1, -2, -3. Now, obviously, or maybe not obviously, the more you make the trigger, meaning -1 versus -2 versus -3 versus -4, that gets more and more and more difficult to do. And the pressure trigger itself is already a difficult triggering mechanism. You can imagine that depending on the patient's weak, or if they're elderly, or if they're really critically ill, that could sort of be a form of torture, especially if they want a breath, but you make them getting a breath so incredibly difficult to do, meaning you set the pressure trigger or a trigger sort of too high, so they have to do a lot of work to get a breath. Nevertheless, the patient has to influence the circuit to sort of pull the pressure out of the circuit, and then once they get to some number, so let's say the PEEP is 5, the pressure trigger is -2, so once they make the pressure -3, then the vent says to itself, oh, the patient must want a breath, we better deliver a breath. So that's sort of the threshold. So that's the first way that the patient can trigger the vent spontaneously, is through a pressure trigger. The second way is a flow trigger. So the flow trigger is, I think, generally what is set. It's thought to be the easier of the two triggers. So there's always sort of bias flow, so sort of flow in the circuit that's sort of going around. So if you have this bias flow and it sort of should be doing this sort of circular motion, but some of it gets diverted to the patient, then depending on what you set the flow trigger, 1, 2, 3, maybe 4, each ventilator is a little bit different. I use servos, so it's usually set at like a 2-liter a minute flow trigger. If the patient takes a little bit of flow in, they can trigger the ventilator. The flow trigger is thought to be the easier of the two triggers. The pressure trigger is the more difficult trigger. So essentially what you have when you have triggering, so what triggering is going from expiration to inspiration. You can do that in 3 ways. The first way is through time. So just every couple of seconds, depending on what respiratory rate you set, the vent will trigger into inspiration, pressure, or flow. Now, moving on to sort of the dssynchronies of triggering. There's 3 here that I have listed, but sadly I forgot one, which would be auto trigger. So the first is ineffective trigger. So an ineffective trigger is when the patient is trying to let the ventilator know that they want a breath, but because of some reason, the vent doesn't see the effort. So for those of you that can see on YouTube and Spotify, I'm drawing sort of in the pressure and flow waveform the flow waveform gets deflected upward, the pressure waveform gets deflected downward. When that happens, the patient is trying to sort of influence the circuit to let the vent know that he or she wants a breath. But for some reason, that effort isn't seen, so it's ineffective. Now, the number one reason that, I'm not going to say cause, but the number one thing you should think about certainly is, does the patient have auto PEEP? Ineffective trigger is a sign of auto PEEP, so you can imagine if you have a bunch of extra pressure left in your chest after your previous breath, in order to generate the next breath, you have to first overcome all that pressure that's in the chest. So if there's already +5 of pressure in the chest, and you set the pressure trigger, let's say to -2, if you had no auto PEEP, you would only need to pull the circuit down by 2. So generate -2 of negative intrathoracic pressure to sort of influence the circuit. But if you had 5 of auto PEEP, the patient has to generate 7 centimeters of water. So the first 5 is for the auto PEEP to sort of get above that, and then another 2 more. So when you see ineffective trigger, the first thing you should think of is auto PEEP. Now, could you have ineffective trigger because you set the triggering mechanism too high? That's also a possibility. So if you set the triggering mechanism too high, made it too difficult, then the person could be sucking down all day on the circuit, but not be able to sort of generate the effort above where it needs to be to generate a volume or a flow or a breath, but you'd still see the effort on the ventilator. But when you see ineffective trigger, the first thing you should think of is auto PEEP. If for some reason you come to the conclusion that there's no auto PEEP, maybe you check it or there's no other signs, then I would check your triggering mechanisms, and I would also check to see maybe does the patient have like neuromuscular weakness perhaps, so they can sort of like generate some effort but can't do enough to generate a breath. So that would be the two things I would think of. The second broad flavor is sort of a delayed trigger. So I think you can imagine if you had the perfect ventilator, once the patient wanted a breath, they would get a breath. Sort of how we breathe normally when either you take a spontaneous breath in or you're just sort of breathing at a quiet rate. Once you want a breath, you could start to generate the effort. Depending on how sensitive the trigger is and other factors, the vent may or may not see the effort at first. So what the delay trigger is showing essentially is if this is your diaphragmatic activity, so your EDI. So if we had a NAVA catheter, so NAVA is this specialized catheter that can sense the electrical activity of the diaphragm that you can also have sort of the ventilator set to, and that's NAVA, which is a whole separate issue. But essentially what NAVA is sensing is like diaphragmatic activity. So a perfect ventilator, once the diaphragm is active, it would sort of fire. The vent would turn on because the vent would know that the patient wants a breath. Now what we see here, and this is just for sort of demonstration's sake, this is an actual patient, because in NAVA, the whole point of it is once the diaphragm is turned on, the vent starts a breath. So that's one nice thing about NAVA. But for here, what you can see is the diaphragm turns on and the vent doesn't see it right away. So the patient has to sort of influence the circuit. He or she starts to pull the pressure downward, and then at some point they've reached the point where the triggering threshold is set, and then a breath is triggered. But from, let's say, point A, where you start breathing or start the effort, to point B, where the ventilator is turned on, the patient is doing, a fair amount of work here to influence the circuit. So, this in of itself causes increased work of breathing. Delayed trigger could be similar mechanisms, which is auto PEEP, because remember, we have to sort of first overcome the intrathoracic pressure from the auto PEEP. So that could take some time, especially if the patient's not really strong. Or maybe your triggering mechanism is sort of too high, just like before. So you set the mechanism too high, and it takes a little bit of time for the patient to trigger the ventilator. So this is delayed trigger. So what you should see in reality is if you have sort of triggering and that's closely related to the patient's, intrinsic, if you have spontaneous triggering, you shouldn't really see the pressure waveform be too distorted before the breath is given. You should just see maybe sort of a little blip down right before the breath is given, and then the vent should turn on. And then depending on your ventilator, we have servos. What you would know is that this little sort of blip down, that is a spontaneous breath. These breaths that are spontaneous on servos, there's a little white dash that's associated with one of the waveforms, either the pressure or the flow. So that's sort of two ways that you know that the breath was spontaneous. One is you see the little white line. I guess there's 3 ways. One is the little white line. Number 2, you should see a little blip down here. And then number 3, in the corner, there's a pair of lungs that sort of pop up that let you know that that was a spontaneous breath. So dssynchronies of triggering so far, ineffective triggering, delayed triggering, both of these are really, the first thing you should think of is auto peep. The second thing you should think of is my triggering threshold too high? Maybe someone changed it, or someone didn't know how to set it at first and they made it too much. Maybe the patient's very ill, or they're weak, or they're elderly, and a normal trigger is just sort of too much for them. So maybe you need to be more cognizant of what you're setting the trigger at. So one of the last ones is reverse trigger, also known as early trigger by some. So reverse trigger really exploded onto the scenes during coronavirus because we had patients very deeply sedated, and it has a lot to do with sort of the depth of sedation. But essentially, it sort of exploits a reflex in our brainstem where when the diaphragm is under pressure and flow, it sort of contracts. So the telltale sign of reverse or early trigger is you have a machine breath start. So you don't see it come down. There's no white line. So you see the white line here, just like I said before. So this breath is spontaneous. This breath, the beginning of it, is not spontaneous, but the patient's diaphragm starts to act after the breath is started. So reverse trigger, sort of by definition, is kind of this double trigger morphology, but the initial part of the breath is machine delivered, and the second part is patient effort, which is what you see here. So then lastly is auto triggering. So auto triggering happens when there's something happening in the circuit that is causing a lot of reverberation throughout the circuit that the vent can then misinterpret as respiratory effort. So in this situation, there's a lot of ringing in the circuit, which is all these little squiggly lines, which can be from a multitude of things, most commonly secretions or blood or just humidity in the circuit, or also very importantly, cardiac oscillations. So with cardiac oscillations, this becomes particularly important, especially if these are causing auto triggers. So if the vent thinks that the patient's breathing and they're not, and it's firing breaths, and then we're seeing that the patient's spontaneously breathing on the ventilator, but they're in fact not spontaneously breathing on the ventilator, that would be very concerning, especially in a situation like brain death. So, being able to identify the possibility that there's an auto trigger is very important. So if there's a lot of ringing in the circuit and there's sort of a disconnect between how fast the patient's breathing when you observe them and what the rate is on the ventilator. So if the ventilator rate's like 40, but the patient's awake and alert and sort of cooperative, or does look like they're breathing 40, you should be thinking to yourself, is there an auto trigger? So an auto trigger happens because, and lastly with auto trigger, certainly if you set the triggering threshold too low, then the vent can mistake any sort of perturbation in the circuit as a effort for inspiration and then fire. So it's sort of a balance between setting the trigger not so high that it's sort of impossible to trigger and causing torture, and not so low that the ventilator just triggers automatically and inappropriately. But whenever you see a lot of ringing in the circuit, or if there's ever a point where the respiratory rate that you're seeing on the ventilator is very discordant to what you're seeing with the patient, you should think to yourself, is the ventilator auto triggering? So it's important to know the triggering mechanisms and their associated dssynchronies, as this can cause a lot of pain and suffering in the ICU, especially if you have something like auto triggering or delay triggering. Certainly ineffective triggering is something very important that we should be able to identify, because it's sort of a cardinal sign of auto peep, especially in people who might not have the ability to do an expiratory hold and like measure the auto peep. I'm thinking more of the pre-hospital folks on the T1s that can't do the holds, and they sort of have to infer from the waveform if the patient has auto peep. So it's important to know. So hopefully this was helpful.